So, David, we're about midway through the Major League Baseball season. It's been an interesting season to date. I don't know how closely you're following it.
I follow it. I follow it, somewhat. I mean, I'm not one of the diehard fans, but I always found Major League Baseball to be much more engaging to me than some of the other really big professional sports.
So, the really exciting thing this year with the baseball season is that there's a player with the California Angels, Otani, I think I said that right, who's originally from Japan. And he's both a pitcher, but he's also leading the league in home runs. So it's really rare for someone to do both. Maybe that's a good transition to the first issue we want to talk about, which is kind of something new and creative and probably our listeners don't know about, which is the Innovate Kidney Care campaign.
Yeah, that is a good. That's a good segue. This is definitely something about a bunch of different groups, including ASN and the National Kidney Foundation, with some of the new players in kidney care, like CVS Health, Outset Medical, Anthem and Cricket, and Home Dialyzers United. And what we've come together to do, and there other people and other groups are welcome to join us. It is more of a campaign, but it's really to address how we regulate the preparation for home dialysis for patients, the training, and all the things that have kind of been standard for quite some time now.
So just so I'm clear, so it's a campaign, it's not a coalition.
That's correct. That's correct. It is a campaign, not a coalition.
And what are some of the goals? Like a year from now, how would we judge its success or failure?
Well, a year is going to be a short timeline for this one. This is going to be a 2 to 3 year one. But in general, what you want to see is you want to see CMS, the Centers for Medicare and Medicaid Services, having a serious discussion about 4 different things. And those things are, first out of the 4 is removing barriers to home dialysis training. So there's more flexibility and personalization for that training and the treatment of the patient that really could kind of help make sure that people who are given that option are able to pursue that option. I'm gonna go through these and we can talk about what that means a little bit. The second one of the 4 is differentiate regulations to expand home dialysis training and support. Then number 3 is to alleviate clinical burden of administrative tasks, to focus on that training and really taking that patient down that new pathway. And the 4th is to allow home dialysis training and support to be delivered in a variety of healthcare settings. And I think that 4th one kind of really encapsulates everything. We are looking at innovation finally, as we've all know. It's been in kidney care and also in dialysis. And basically, the rules for how you prepare someone for home dialysis or where you can do it and the various ways in which you can be involved have been kind of written very strictly for quite some time. And they really are basically kind of handcuffing people and handcuffing groups. So, I mean, if you need a home training program, right now, the way it works, in order to get certified, you have to have everything in that program that a dialysis facility has on its location. And that doesn't necessarily make sense with new dialyzers and new devices coming on the market, and just being able to really make sure that a person who wants to go to do home dialysis has a chance to get trained properly and in such a way that really works for them.
So I'm listening to you and I'm just thinking about kind of what the approach would be. It sounds like it's going to be much more of a regulatory approach than a legislative approach.
I think that is absolutely correct. So, I mean, the idea, imagine this. Imagine one of the things that we're beginning to see is a lot more transitional facilities. So let's say that, God forbid, that you crash into dialysis. You go to the hospital and you're told that you're sick because your kidneys are failing. And, I'm the nephrologist and I really don't have any sense of what your home, conditions are, if you've got a caregiver, how dependable that caregiver is, all of those things. But, so we often have a situation where we just default to writing that prescription to go to the local in-center dialysis facility. And that is no criticism of those facilities. They have done a really good job of helping thousands and thousands of people. But if you're someone who says, I really would like to pursue something different like home dialysis, but I don't really know, and I'm not sure I can really make that choice here. We are looking at such things as transitional facilities where you might be sent to really kind of be educated. You might actually have to go someplace else to actually be treated with dialysis during that time, but that the transitional facility would have the ability to really be your care coordinator and prepare you for home dialysis and evaluate if you're okay for home dialysis, and then kind of become the supervisor of that. So it's a lot of different ways to go about it. And that's the thing that we want to see, is we want to see the barriers are really opened up so they can be more innovative. We got to keep the guardrails on for patients. We know that. But right now we're dealing with a set of rules that really haven't been adjusted for quite some time, and it's worth having a conversation about.
Yeah, and I want to make sure that we emphasize a really important point here, which is it's a little bit of a chicken or the egg situation, in the sense that if on the one hand we're making these huge investments in innovation and we're trying to improve how care is delivered, where care is delivered, the quality of that care, simultaneously we also have to make sure that the regulatory and reimbursement environment is similarly changed so that it can accommodate these innovations. And you kind of can't do one without the other. And I think historically we probably haven't thought as holistically about these issues as we should.
I totally agree. And the one thing about the regulatory process, it does move slower sometimes than other options, but it is governed by a very clear, transparent set of laws around how the government can conduct its business. So this would be something that would go through rulemaking. This is something that every party that would like to can have a say in and can express comments and can register their support, like, dislike, disinterest, or whatever of various proposals or ideas, and come up with something that CMS thinks makes sense to allow that innovation to occur, but also still protects patients and is not designed to penalize existing in-center facilities.
So I'm going to move to our next issue. So the Chicago White Sox are leading the American League Central Division, and they have a new manager, Tony La Russa, who returned to baseball after several years of retirement. So, and he's about the same age as President Biden. So I'm using Tony La Russa as kind of a transition to the Biden administration's executive order and the role of the White House Office of Management and Budget related to diversity, equity, inclusion, justice, and their request for information. Can you just give us a quick sort of overview of that effort as well?
Very quick overview at a very high level. Basically, the Biden administration, within its first day, signed an executive order titled Executive Order on Advancing Racial Equity and Support for Underserved Communities Through the Federal Government. This is one of the most far-reaching executive orders I've ever seen. That goes for the fact that this executive order is not just about healthcare. It's about any service the federal government provides. And it has ordered every aspect of the federal government, and most importantly, the Office of Management and Budget, which oversees the creation of budgets every year, to take a look at where the money goes, how it's contracted out, how procurement occurs, everything imaginable, to say, are we doing this in such a way that really will make change and really open up programs for everyone, and particularly for those communities who have been less served by programs. So, as you can imagine, in KinderCare, that's a heavy lift.
So, can you just give us a sense as to what some of the recommendations, sort of how ASN is going to respond, and what some of the recommendations would be?
Sure. The recommendations are really the work of ASN over the last 5 to 10 years. I mean, there's a lot here that the ASN has been laying the foundation for a long time. So it's going to start with the most basics, which is we have to get back to a conversation about kidney screening guidelines. And I know there was some concern at one point from the United States Preventive Services Task Force that the guidelines were not exact enough in the past. It wasn't clear where they were going. But we're at a stage now where we've got to return to that conversation. So you have things like SGLT2 inhibitors sitting there now available for use, and the people who might be able to really truly benefit from them haven't been diagnosed because we're just letting them go until they crash into kidney failure. So that's a very good example. But it's also going to be the things like the kidney disease education benefit, which greatly needs to be both expanded and needs to really become clear and transparent about what should be provided in that education benefit. There's a lot about home dialysis that we're recommending, a lot about telehealth, a lot about transplant, a whole lot about transplant. This is up on our website now, and you can take a look at what the letter says to OMB, and it is it just covers a whole lot of different fronts. But you can really zone in on, as you can imagine, every nephrologist knows how inequities and disparities play out when it comes to home dialysis and when it comes to transplantation. When all the things that happened that have much better outcomes, more for white Americans than it does for other Americans, is definitely writ large all over kidney disease.
So before we move off this topic, just to help people understand, because it's a little bit of inside baseball, if you pardon the pun, but the White House Office of Management and Budget. So OMB is the sort of largest office within the executive office of the president. And I tend to always think of it from a budget perspective. And we've talked a lot over the years about sort of how the president's budget is developed and released and provides sort of the initial framework that then is handed to Congress to start to appropriate funding and sort of think about what the funding priorities will be. And that's so plays a huge role in that process. What we don't talk about as much is the management side of OMB. So just so I'm clear, this effort's really the management side, as they're looking at agency programs and procedures and policies and making sure that they're aligned with this overall set of priorities around diversity, equity, and inclusion.
It's really interesting the way they organize this executive order, because you're right. We think of OMB as the bean counters. No offense to everyone from OMB, but that's the way we think of them in Washington. The bean counters, the ones who look at, say, these numbers don't add up, or these don't really kind of reflect what we're going to see in tax income or revenue. But what they did was they very smartly did something. They front-ended the work and basically said to each agency department, you've got approximately 60 days to start getting your thinking together about what needs to change in your area. You need to start thinking right away, and your process needs to be in place within 60 days. You aren't going to have all the answers within 60 days, but you have to have your process up and running. And that was the first stage. So you're looking at like April after the inauguration this year, for agencies had to be at that point. Then you're looking at this time in summer, for the time at which OMB gets input from people everywhere about how the programs that impact them could be housing. If you're an advocacy group on housing, it could be defense spending. It could be many, many different areas. Ours, of course, is healthcare and kidney care. And so what this stage is about saying, okay, this is the public's chance to say to OMB, if you want to really affect change in the programs that we are dealing with, here are the things that you need to look for. So the public gets a chance to tell OMB that before the departments do. And so what will happen is we go into the fall and you get ready for, the beginning of 2022, and the Biden administration is putting together their budgets to submit for each one of the departments. Those budgets are now going to need to go through the process at OMB of saying, okay, let's see how the budget you've made aligns with goals you've outlined and the things that the public have said. Now, I'm sure that the agencies and the public are not going to agree on everything, but the point being, they will actually not be just doing the bean counting. They will not just be looking at saying, okay, the president's priority got this much money. That's what we wanted. That's great, or something of that nature. This will be along the lines of, we're looking at this program and we've got a lot of concern about, so for example, the transplant for kidney patients. And we've got a lot of concern about why certain groups do not get, waitlisted, do not get evaluated, do not get offered organs, are far less likely to get an organ, are far more likely to be provided an organ which is substandard, which is what happens in America, particularly for Black Americans. And so what in your budget is designed to try to help fix some of that? So that's a kind of a completely different dynamic and conversation that really hasn't been occurring on a regular basis.
Yeah, and just before we move off this issue, just to remind everyone about executive orders. So essentially the way they work is that the president can sign them. They tend to usually include policy directions and philosophies, if you will, and they can either be overturned by the judicial branch so that there's an opportunity for someone to sue and then for it to go through the court system and ultimately to the Supreme Court if they support it as being unconstitutional. Or another president can come in and undo previous president's executive orders. So I think it's fair to say that this set of philosophies or this approach is going to sort of be how things are done, as you indicated, next year and beyond.
Yeah, and like I said, yes, another administration can undo them. They're not actually that easy to undo if they're really extensive. And so, I mean, that's when the really extensive ones get into place. You have to be careful what you're doing to try to undo. So I have a feeling this one's going to be around for quite some time.
Yeah, and that provides sort of an opportunity for us to transition to our third issue. And staying in Chicago, during the seventh inning stretch of Chicago Cubs games, they sing Take Me Out to the Ball Game. And of course, the chorus includes it's 1, 2, 3 strikes, you're out. And you haven't lived until you've heard Bill Murray's version. So the attempts to defeat the Affordable Care Act, are those finished, do you think?
Well, you can never say everything's finished. It's always, something to happen. But I think there is a really strong sense that at the Supreme Court and for the foreseeable future, those who have tried to use the courts to overturn the Affordable Care Act have had their third strike and they're out. As one recent blog writer wrote, they were actually sent back to the shower. They were sent back to the locker room to take their showers. So, we have one case right after, not long after the Affordable Care Act went into effect, and it was ruled on in 2012. And that's the one where the Supreme Court said, well, you can use the tax. So therefore, since they have the power to tax, and since you have the power not to put your Medicaid program in, then you really don't have a case. So that case was a real narrow 5-4 vote. It was a big victory, very big victory. And that's the one that John Roberts, the Supreme Court Chief Justice, sided with. So that was the first strike. That was the first big case that went out. Then in 2015, we had the next big case. And that was one that was a little bit more nuanced in terms of receiving income tax subsidies and how you ran the exchanges. But that one also, with John Roberts as the Chief Justice of the Supreme Court, a Republican nominee, that court also ruled 6-3. So that was second strike. And as you can see, the numbers are not going well for those who want to repeal the ACA. And then when you get to the last one, the decision was just released in June here in 2021 in California versus Texas. 7 out, and that includes the 4 Republican nominees. 7 to 2 basically ruled that the states that had made that claim in that case had no standing. And it's a very interesting thing because once those who really had wanted to undo ACA had really kind of forced out some of the more important things and the penalties, the court's position was, well, now you've taken out the injury. There's no more injury, therefore there is no standing to be in federal court. Nobody's been hurt here, and threw it out completely. And that's strike 3, you're out. And the reason why this baseball analogy it kind of stands true is because some people thought Chief Justice Roberts was being a little bit flip when he was being when there were hearings for him to be confirmed to the Supreme Court and the Senate, and he basically said, I'd see the judge's job as an umpire, and their job is to call the balls and strikes. And when it comes to the ACA, he has been pretty much straight on with that. He's been very clear that he didn't think it was the role of the courts to come in and make this decision. If the people who want to overthrow the ACA or overturn the ACA want to do that, they need to go back to Congress and they need to deal with it. They need to get the votes and they need to deal with the political fallout if there is any. And the courts can't do it for them.
So as we've talked about before, that the Biden administration, that sort of healthcare leaders who've been politically appointed, all have strong sort of backgrounds in and around the ACA. Given sort of what's happened on the judicial side, what's likely to happen now, both from the executive branch as well as from Congress, as it relates to the Affordable Care Act?
Well, it's funny because if the Obama administration was the Affordable Care Act, the Biden administration is looking like it will be more the Affordable Care Act than the Obama administration, which is not surprising because it's taken some time to get back into the White House and to try to protect it. But I think you can see the executive branch moving very quickly to really try to put sound footing around something that the courts have been unwilling to just fiat out of existence. And so that's really important. And it does say to Capitol Hill, basically, guys, if you want this undone, you're going to have to get the votes to do it. And you're going to have to get it through a veto. And that's really becomes a bigger lift. There's a side battle brewing, and that side battle is going to come after this, which is, and we're already beginning to see it. The side battle was under the Trump administration, the expansion of what we call the 1115 waivers. And those are the ones that allowed, those waivers allowed Medicaid programs to do things like the work requirements and so forth. I think there's going to be some real push to get clarity around what 115 waivers can do. And one of the reasons why is because some years ago, the 115 waivers were relieved of their responsibility to test for human impact, which sounds very strange, but that is actually one of the things that's really, if that is put back on the table, it is going to make them much harder to use, and also to be defended in court, the way the Trump administration did when the many different waivers that it was giving, to be basically really tighten up Medicaid and make it have to be a work for coverage program.
Well, thanks, David. And don't forget to buy me some peanuts and Cracker Jack.
Okay.